This
too. So
conference
who
will
all's
now be
here?
recorded.
Can you guys hear me?
Yeah, we can hear you.
Michelle's here. Okay. So I see Christine chatted in that she's here. We know Christine's here, Gary's here, Michelle's here, Melissa's here. I heard Kirsten. Who else is on the call?
Becky's here.
Carol's here.
Becky. Hi, Carol.
Madeline and Amy are here from the Cathedral Square with Kirsten.
Hi, everyone. Lisa Page is here.
Hey, Lisa.
Sabina is here. Good morning.
Good morning. Someone is listed in the attendees as RSPM. I'm so curious. What does that mean?
Oh, I think that's me. It's Resident Services Program Manager.
Perfect. I haven't had enough coffee to figure that one out yet. I see Pilar's on the call 3 times, so okay. Are we missing anybody? Oh, Kenneth. I don't see Kenneth yet.
Jennifer Hunter is here, but I'm having a hard time signing onto the web because of my computer.
Yeah, my
computer's doing
something weird too. So I guess I'm in there. So I'm there.
I think it's the update. I think the update they did yesterday messed with it.
Oh, jeez.
Well, we are going to record it too, so if you aren't able to get on now, you might be able to look at the stuff they're showing on the screen later. Okay, so I'm just going to go ahead and get us started. I first just wanted to introduce, we have hired a new health systems educator, which is the title for Christy Palman's role, and that is Casey Doerner, who is coming to us from Rural Edge. Thank you, Gary. So, Casey, do you want to just take a minute and introduce yourself? You might have to unmute.
Okay, yes, I think I have. Am I unmuted?
You are.
Okay, hello everyone. I'm Casey. I've been a wellness nurse with Rural Edge for 4 years, and I was a wellness nurse for a couple of years early on in the program also. So I've been with SASH for quite a while, and I'm really excited to be working with the nurses all around the state and getting to know everybody and seeing how things are done outside of the Northeast Kingdom.
Well, we are so happy to have you here, Casey, and I have to say, man, you hit the ground running. She is already in it and digging into this big grant that we had gotten through VDH. So, like, she started and we put her right to work, so thank goodness you're here, Casey. I think that your information is going out in the Beat tomorrow, so everybody will have your contact information. But I just wanted to take a second and, welcome you officially, so welcome. And then I also wanted to give you guys a brief update about Care Navigator. I am meeting with Robin Skiff tomorrow to wrap up any final questions that I have about the process for the lead care coordinator payments. And I'm creating a webinar that I will offer to staff, but I wanted to get a feel first. Do you guys want me to offer that to you first so you can watch it and know what the staff are going to be hearing? Would that be helpful? Hello?
Melissa, can you give us a little more detail?
Sure. I mean, I'm not sure exactly what to say other than, because I don't have the thing in front of me, but it's going to walk through the process of the lead care coordinator and the payments. So there's not a whole lot of detail about the payments, but it's really sort of what's expected of the lead care coordinator in order to receive the payment. There's sort of like some boxes that you have to check and things that you have to do. So I will be going through sort of what an attribution list is, how people are assigned as a lead care coordinator, what they have to do once they're assigned in order to receive that payment. Does that answer your question?
Yes, it does. And so how will that fall true for Rutland, who's using the Cerner program?
They have told me that it will count for you as well, because Rutland Hospital will be sending clinical update to OneCare once a quarter that will include lead care coordinator, that will include shared care plans. So they have assured me that it can work for Rutland too.
Okay, just double checking.
Yeah. The thing is, you may find it beneficial, Carol, because it does talk about sort of what needs to be done as a lead care coordinator. It might be a little less beneficial because your system that you're using is different. So, 6 of one, half dozen of the other. It helps you know what you need to, like what tasks you need to complete. For people using Care Navigator, it actually has screenshots that show you, go click this button. That part probably wouldn't be as beneficial.
Right.
So any other thoughts on whether or not you want to preview it, or should I just go forth and for it for staff?
Melissa, I just a couple questions, and maybe I missed it. I'm sorry. You're sending the webinar out to people who have been identified, or is all SASH coordinators going to take this webinar in case they get identified?
I'm going to offer it to anybody that wants it. It's going to be live. We're going to record it, and then if people can't make it, or if they start later and they want to watch it, they can watch it then.
So for me, it would be great if you're able to send it out in advance, in case some people that are on my team just have no idea what we're talking about. You know what I mean? If they're like,
so would you rather just, since we're recording it live, do you want me to actually just send the PowerPoint?
Yeah, that would be great.
Okay, so rather than actually demo the webinar, I can send the PowerPoint. That's a great idea.
Perfect.
Anyone else have a vote?
Hi, this is Christine. I'd like to I would like to just attend the webinar or view the webinar.
Okay. Thanks, Christine.
Melissa, I think I would like to as well.
I'm sorry, you would like to cut out?
Maybe in advance, just kind of take a look at it.
At the PowerPoint? Sure.
Yeah. Or the webinar. I mean, if I can look at the webinar, that would be great too. I think my folks would probably have questions without a doubt.
Okay, so I think what I'll do, because I want to get this out kind of quickly, is like hopefully within the next few weeks, I think what I'll do is I'll send out an invite for all of you guys to come, and I'll preview the webinar with you. And if you can or want to make it, you can. If not, I'll attach the PowerPoint to that invite, and you can just preview the PowerPoint. How's that sound?
Sounds great.
Sounds good.
Okay, perfect. Thank you guys very much. I'll just go ahead and do that. And then the only other thing on the agenda that was from me is really I don't have enough information to even talk about it, but our IT department was kind of perusing the idea of, instead of us sending monthly status reports out to all of the staff and you and everyone, creating a SharePoint where people can go in and get those documents. The reason I say I don't have enough information is because I have a lot of questions about security and how would you only have access to the ones you're supposed to have access to. But the reason this came up is because as we share more and more information on that monthly status report, I get a little more and more concerned because we send them to a lot of people and there's a lot of room for error. So I just wanted to put out there that this is a question, and if anybody has any ideas or thoughts around it, to just let me know. I mean, I don't think that we need to dig into it right now, but if you wanted to shoot me an email, the idea being instead of us sending a monthly status report out, we would just send an email saying they're up and ready to go, and you would then go to the SharePoint and retrieve it. I don't know. Any initial thoughts? We're meeting with IT next week to kind of dig into the logistics and how it would work, and I just more than anything want to make sure that once you're in the SharePoint, you don't have access to everyone's monthly status report, but just the ones that you're supposed to have. So I'm thinking if you guys have any thoughts or initial questions or experience with something like that, if you want to send me those, I can bring those to the meeting with IT next week.
Melissa, this is Gary.
Hey, Gary.
Quick question. Who would have access for SASH staff? Would that be all SASH coordinators or managers?
Yeah, that's a great question, and it's one that I can ask. The way I envision it is it would be the managers, the SASH coordinators for their specific panel, and then also wellness nurses, which might be fantastic because we're not necessarily sending monthly status reports out to all nurses, and that's because not all nurses have a business account. Some of them have, I mean, there used to be one years ago that was like hotgranny92 at, Gmail or something. So we have said that the only time we will send a monthly status report to a nurse is if they have a secured email through their agency that they work with. So it would be a way that nurses could go in and actually retrieve their monthly status reports too. So I would envision, Gary, you would have access to all of your panels, then the coordinators would have access to their panel, and the wellness nurse would have access to their panels as well. Did that answer your question?
Yes, it does. Thank you.
Yeah. Okay. So I guess just know that that's something that we're kind of looking into. I don't know if it's possible. But sort of first level, first tier, it's a question that we're asking. If you guys have any ideas, questions, or thoughts, just let me know and I'll bring them to the meeting next week.
Melissa, can I ask a quick question? Is it still the goal that eventually somewhere in PHL's future there's going to be a sort of a dashboard button to run that report at any time? Or is it always going to be? Yeah.
No, that is the goal. So I can give you a little update about that. We had been.
No, just don't take up the time. I just was wondering.
No, it'll take me 2 seconds. Yes, that's the goal. It's looking like it's maybe 6 to 9 months out. How's that?
Okay, that sounds perfect. Okay.
Okay.
I love the idea of having it on a share thing. Yeah, don't email it. Put it somewhere and we can access it. That's much easier.
Okay, great. If anybody wants more details about the PHL issue, just shoot me an email. I'll be happy to tell you about it. Okay, so that's all that I had. I'm going to move it over to Madeline, who's going to show you a new QA report that'll help get us through this interim time when we don't have reports. It's pretty amazing. And then also, they're kind of changing up the PHL call, which has been really fantastic, to go from just like how do you use PHL, because I think people generally get an idea of how to use it now, to what do we know because of all the information that you're entering into PHL. So I wanted her to show you guys the stuff that's going on those calls, mainly so that you can help encourage your staff to attend, because they're pretty fantastic and they have a pretty low attendance. So, Madeline?
Yeah, sorry, Melissa, which one did you want me to go through first?
Totally up to you.
Okay.
However you got it geared up works for me.
Okay. So we have put together kind of like I guess we're just calling it a QA sheet, and so we're hoping for feedback from all of you to see if if this is something that you might find helpful to receive on a monthly basis. So this would be kind of like your own report. So each of you would get your own individual report that would kind of aggregate a lot of the information that gets sent through the monthly status report. So it's just like quicker to digest some of that information. So I'm just going to walk you through what we have so far. And just let me know if you have questions. Is everyone able to see my screen?
I can see it.
Okay. I wasn't sure if we had some people who were just on audio. So this first sheet is just like your panel numbers. So each panel gets their own record, and all of this information you can get from your monthly status reports. It's just maybe a little bit easier to see all of the numbers kind of added up.
Madeline, you might want to hide the bar at the bottom so I can see the tabs at the bottom of your screen.
I'll hide.
There you go.
So the first sheet is just the numbers of your full and auto benefit, the total, and then your percent auto. So just kind of the straight totals there. And if there aren't any more questions, I'll just keep going.
Can I ask a quick question? Only because we had that, this is Sabina, last time. The percent auto is of 100 or of the people that are enrolled? So if I have 104, and I can't do the math this early in the morning, if I have 104 enrolled, but I really only, it's counting to 100, so the percentage is the auto of 100 or of 104?
104, yeah, so that first record, 10 divided by,
yeah, so is there a way to make it out of 100, only because that gives a more accurate number? You know, for people that are over-enrolled, it sort of would work against them if they have, anyways, yeah, is there a way to do it by 100?
So maybe Sabina, let's walk through the next sheet and
I'll get
your feedback after that one, because I think it might be what you're bringing up.
Okay, sorry.
No, you're fine, thanks. So this next sheet is kind of repeats some of that information, but what we're now taking into consideration is that different panels have kind of this different minimum, I guess, that we've established for being considered, I guess, like at capacity. So that's going to depend on whether or not there are community members being served at that panel. So we have on-site, mixed, and community panels. So I believe the minimum for on-site is going to be 90, mixed is 80, and I forget what community is, 70. So this kind of gives you what each of your panels, kind of just like that minimum enrollment based on your panel type. So then this next column, 10% or less, it'll just be yes or no. And that's just going to be the number of auto out of the total active participants. So I'm not sure if that gets at, Sabina, what you're kind of describing. So then this next column, column G, is just another yes or no. Did the panel meet the minimum enrollment? So that'll just take in the full benefit participants, because that's what that number is supposed to be, is full benefit. So, Sabina says yes.
Yes, I just found my unmute button. Yes, that's absolutely it.
So then the number to reach minimum is, it's just the your minimum enrollment minus what your actual enrollment is. Just to kind of give you a quick, like, where you're at for enrollment. Okay, so I'll just move on if no one's got questions.
If you know, perfect, ignore me.
Let's see here. Oh, and then use and disclosures, just what the percentage is of current use and disclosures. So that'll be use and disclosures signed in the last 12 months. And that 12 months is always taken from the date that the data are pulled. So this last month was January 28th, I think. Yeah. Then we have wellness nurse assessments. So up to date being in the last 12 months from the date the data are pulled. Wellness nurse assessments we kind of do based on different screens that are supposed to be filled out or asked of the participants. So right now we do the falls risk assessment, that question on the general health assessment tab, whether or not the participant has an annual exam with their physician. And what was the last one? I always forget. Falls risk, PHQ2. Thanks, Michelle. So if those were asked on the same date, we kind of figure that's a good indication that that was last time the wellness nurse assessment was completed. And then, and of course, that's just for your full benefit participants. So number up to date, the total full. And we have this next column. We've created those visit types and reasons to indicate when people are in the entire assessment. So this is just a percentage. It'll be the number that has declined in. And it looks like we have someone who is not muted, just FYI, unless you have a question.
That was me again.
Okay. Hey. Do you have a question?
No.
Providing comic relief.
Yeah. Yes. Sorry, maybe I should have gone PowerPoint first. This is so dry. So then we have the Lubin up to date, just number. That's self-explanatory, but let me know if you have questions. And then this last column is number of participants on the panel who don't have any diagnoses entered, just kind of as like a indication that that might need some investigation, just considering that the participants have on average 5 or 6 chronic conditions. So to have 0 is just, Okay, SASH coordinator assessments, kind of the same thing. Not sure if you want me to go through these first 2 columns. SASH coordinator assessment, it will be like the last 3 questions on that tab.
I'm messing with you.
And then, advanced directives? Yeah, OOD is out of date. So not that the advanced directive is out of date, it's that it hasn't been assessed in the last 12 months. So if there is a yes answer, then we just figured they'd still have it. But if it's a no and it hasn't been assessed in the last 12 months, that's when we combine those 2 things.
So basically, you would be assuming that the question hasn't been asked. So there was a no and no activity on that question?
Yes.
In like over a year?
Yeah.
Okay.
And then the housing question. There's no data on where the participant lives, as in like either the community or the hub. So I think that's question 1 or 2 on the SASH coordinator assessment tab.
Okay.
So this next tab is might take some explaining. I know many of you don't do a lot of direct data entry, but so in PHL, anytime that you want to like document an encounter with the participant, so whether it be a phone call to the PCP or an entire annual assessment, you have to create a visit first. So this is kind of our way of indicating staff activity, because we don't have ready information about like logging into PHL. So this is kind of what we use instead of that. So in the last 6 months, we kind of compile the total number of visits created by staff. So I know some panels have like 1 person doing all of their data entry. So you might see really low numbers on certain staff that that's the case if they're not the ones doing the data entry. And then this is just an indication of your panel. So like if you have an on-site panel, you should just have 100% of your panel in this hub column. If you're mixed, you'll have a combination. And then assuming if you have a community only, you would have 100% in the community. So this just shows kind of the distribution of those participants. So each row would add up to 100. Okay, did I bore you all to death? Great.
Madeline, can you click back to the enrollment tab for a second?
Yeah.
I was trying to follow something, and I haven't gotten near Sabina's coffee maker, so I just have to look at this again. So I'm having questions, and maybe it's my math. I'm looking at panel B. So I have 75 full. I have way over what I need for auto, so I'm only counting, I'm assuming 9 as 10%, correct?
So from what I understand,
Yes, that's correct.
we have a minimum enrollment of full benefit. That's is that not correct?
I think Melissa just answered.
Well, so I'm looking at the
Yeah.
number to reach minimum is 15. 75 and 9 is 84. If I need to get to 90, why is number to reach minimum not 6?
No, you're right, Jennifer. That's correct. So 90 is the number, but we have said that 10% of that is okay to be auto. So really, I think that, Madeline, we want to make that minimum enrollment column D reflect what it would be with the autos, so 81 in this case, and we can go through and adjust that. But yes, you're absolutely correct. So then it would be 75 of 81, and then the number needed to enroll would be 6.
Okay. Just in terms of people, I get that there's room for more, but just people knowing how many more till I'm feeling like I'm in good shape. Sounds good?
Right. Yep.
I think we need to
That's
double
a great catch. I think that
Yeah, I'm not sure I'll get it.
Can't do that.
As long as Melissa gets it. Okay, so
we'll chat. Yeah, no, that makes total sense.
I guess, yeah, I thought that the total, like, for like an on-site panel is like 100, but like 10 of them are auto, so the minimum, so okay, so I have that a little.
That's way too simple.
Yeah.
Way too, come on.
Okay. Any other feedback? Is there like other information that you feel like you're not really seeing included that would be helpful? I guess you don't have to answer that now, but okay.
This is Kenneth. Is there anything about new enrollees and discontinued enrollees? Is there any way of counting ins and outs?
Yeah, I think we could manage that.
I just know that, when a panel can feel much busier when you're enrolling a bunch of folks, and not sure if that would be helpful for others, but it would for me.
I think that sounds like a good thing to keep track of.
Kind of like the turnover in your panel,
Yeah.
right? Like within the last year or something. That could be interesting because it also points to the activity around training, onboarding, and the effort that goes into that on a yearly basis. Well, they talk about turnover of participants and turnover of staff. Oh, sorry, two different things. Yeah. Sorry.
It's still both ways. It's a lot of work.
Yeah. That's why it's a lot of
like
work.
number.
Yeah.
Be sure it's not much.
It's really hard to get up this morning when it was so warm yesterday and it's so cool today.
I was taking notes. Maybe even like reason.
When you say NO exit there, you mean number exit, not no exit?
Yes. is a no exit program.
Yeah.
You're in for life.
I just have to say I love this because this is what always is when you talk to Madeline, you're like, oh, I have this idea. And she instantly like just goes to work on it. Like she's creating it right now as we're talking in real time. It's just awesome. But moving us along because of time. Sorry, Madeline, I don't mean to interrupt the process. But thank you. That was great. And I see that Sabina said they're fantastic. Pilar is asking how often we get the report. So it sounds like people are thinking this is a good idea. I think Pilar, it comes out monthly with the monthly status reports. And I know that for the admin team, we have one that looks at the whole state. And it's super helpful because it's just an easier way to sort of wrap your head around like a snapshot of where are my panels at, how are they doing, which ones do I need to reach out to. So I'm glad that this will be helpful. And then if you, Pilar, love it. Great, thank you. If you, Madeline, could jump to the PowerPoint, I think that would be great. Thank you.
So this is a PowerPoint that we had shared on the last PHL call, or data call. Just wanted to share it with you, one, because it's really great information. We've had a lot of awesome progress out there with assessments and getting data entered. So we shared this with staff just to kind of say, you know, great job, but it's also kind of where we're moving that call, and so we kind of wanted to put in a plug with all of you to let you know that we're trying to be more, well, I guess just share more data as far as like really anything. I mean, we've talked about like panels risk of prediabetes. We did this information about assessments, getting those improvements over time. I know we're going to end up talking about some like mental health data. So just kind of like to let you know that it's not really all just like open Q&A format, that there's a lot of really good information that we share. And if you aren't able to join, which I know is the case, that's the third Tuesday of the month, and it's just always booked by one of your regular meetings, that we do record it and share it on STAR. So I'll just go through this quickly. So this, again, is what we shared on the last PHL call, and to show the wellness nurse assessments and how much they've improved. So back in August, we were kind of like, oh, wow, these are, you know, they seem to be kind of low as far as how many people have actually had a wellness nurse assessment in the last 12 months. In fact, on average, I think panels like had like 58% of their participants with an assessment in the last 12 months. And by December, the average increased to over 70%, which was really awesome to see. And you can see just the general distribution has shifted pretty significantly. And we even had one panel who was at 100%, and I forget who that was. It was Enosburg.
Enosburg.
And then just like housing data, we used to have, or we had some missing information on that. I'm not really sure what this was, actually, now that I'm looking at it. I think it was just like to show that some of the housing location and
the housing community.
Yeah, that question we used to have. Let's see here. Yeah, like on average 80 or 88% maybe in August had that information there on average, and that average has increased. And same with the advanced directives. So the average used to be around 63, we'll call it, and that has jumped up pretty significantly. So this one's a little hard hard to wrap your head around because zero diagnoses is something that we want to see decrease over time. So the average has decreased, which is great. And then we were at one point experiencing just like a ton of duplicate records. And so this was a lot of effort with Michelle and Jen doing those site visits and really working directly with staff to kind of clean up their data and get rid of duplicate records. So in March, we had a surplus of 166 records, and there were even as many as 6 total records for any one person. And that had decreased even in August. As of December, and only 16 duplicate records. Wonderful. I think someone may not be muted, just the FYI. So in the next quarter, we've kind of decided that there are some other areas of focus that we should kind of look to. Use and disclosures being up to date. Every month, about 100 to 140 participants actually lapse on those use and disclosures. As of December, we had 516 of our full benefit participants with an expired use and disclosure. And of those, nearly half of them lapsed within the last 2 months. So it's just kind of something that we want to focus on and kind of maybe start initiating those getting re-signed maybe 2 months out just to get that on the schedule so that people aren't lapsing. Oh, and this is just to show kind of a comparison between the SASH coordinator assessments and where we were in August with the wellness nurse assessment. So the distribution on the right is where we were in August for the wellness nurse assessments, and we've seen just such a drastic improvement in those. So this is where we stand with SASH coordinator assessments, and you can kind of see that the average is really close, and that distribution is very similar to where we were. So it's definitely a possibility to get those, I guess, up to date. That's all I got.
Thank you so much, Madeline. That was great. Does anybody have any questions about what she shared?
Melissa, this is Carol. I just, I know that I had gone to a meeting recently, and one of the questions was to many of the organization is, you know, what kind of data can you bring forth that would be helpful or contribute to, you know, the whole cause of what we're trying to do as a community. So, you know, I don't know if there's any data that we can provide that would be useful. You know, the chronic conditions is helpful as far as data. I know they work a lot with, Rutland's working a lot with sepsis. I don't know, that's not something that we can identify, I don't think, in our PHL, but, you know, what could we provide that would be helpful, I guess, to the rest of, you know, to bring forth to the meeting or to, you know, some of these, you know, what everybody else is trying to work on as far as, because I think we're all sort of focused on the same thing.
Yeah, so, I mean, if you want even like just kind of a snapshot like profile of like your be it your panel or your county or DRO. We can certainly provide some a proportion of people with different chronic conditions. We have, anything that we collect data on, we can certainly provide reports on. And if you have specific ideas in mind, you can shoot me an email directly. This is Madeline, by the way. It might just take a conversation about what you believe might be interesting to bring to these meetings.
I think the use and disclosures or the advanced directives is, how many folks have advanced directives. That would be, I think, beneficial to folks. But, I just didn't know if anything else that would be helpful or to be useful for us to share with the community when we go to some of these meetings.
Carol, this is Molly. I'm assuming you're talking. Hi. I'm assuming I love your question. I'm assuming you're talking about the Accountable Communities for Health meetings you go to.
Yeah.
Yeah, and I think you're absolutely right. You want to be thinking about what you can share as the representative from SASH and from affordable housing. And clearly we have a plethora of information that you could share. And I think, as Madeline said, you should just be thinking about, okay, what's asked in the assessment, because as long as it's asked, as long as it's being inputted into PHL, then Madeline can run, a report for you that's either specific to a particular panel, or maybe it's for all the panels in your county, which I think is probably what that group would want to see. And it would show them that, wow, SASH really can get down to some pretty granular things with their participants, which provides really important input for that community meeting, trying to figure out what to focus on. So, I think that mental health stuff is really popping with most of the groups. So, sure. So, there's lots of things we could run around mental health diagnoses in SASH. Screens on suicide risk. Just think about those kinds of things. And then, you just want to let Madeline know. And that's true for all of you, because I know all of you are going to these, not all of you, but most of you are going to these Accountable Community for Health meetings. They're all called different things, whether it's Thrive or Catch or whatever. But yeah, the more you can share information about our participants and their vulnerabilities and what we're doing with them, the better. Go ahead, Madeline.
So just as an example of something that is pretty easy to do, this is something I put together for our own internal use, but if you want to see it by your own county or your own panels, your own DROs, we can certainly do that. So this is really just a quick snapshot of our current active participants, and this is a sneak peek for the next PHL call. We're planning to share this on that as well. So just to kind of give you an idea of what is.
Yeah, that would be great, especially the drug and alcohol piece, how many folks within our DRO have addiction issues. So yeah, that would be very helpful. And I didn't know there's no way to capture how many folks have palliative or hospice.
Not unless we ask that.
Not really. The only way you could capture that would be based on a referral. So you could say, here's how many people we referred to hospice, but that's really, there is no question asking if the person is currently receiving hospice or palliative care.
Right.
That's a really great question, though, Carol. Huh. Okay.
This is Kenneth. One thing I've realized, we're not able to report a lot of good things that happen, and it's not like we can control falls terribly, but you can report the response to a fall. And so whether it's transition support provided, within 48 hours to somebody that fell, or that somebody that came home, are we able to somehow make it so we can capture that, because that's a lot of what we do. And I don't think you can pull it out of the data the way we're putting it in right now.
Well, yeah,
There's nothing.
I think it depends
There's nothing.
on what you're tracking in, because we do have, like, I mean, if you're entering the date of the fall, and there's, well, actually, there are a couple ways of looking at this. So we do ask date of most recent fall, and we can look to see if there's been like a through patient ping, if they're on the roster, if there's been like an ED visit tied to that. And we can also see, because there is a visit reason for transition, right?
Yeah, I mean, I think if we were to somehow capture how often we're involved in transitions work, and if, to me, there should also be a transitions falls, because something needs to indicate that we're following up on a fall. That's the most important thing a SASH coordinator can do, wellness nurse. And we're just not capturing that in the PHL data.
Okay.
Thanks, Kenneth. That's a really great point. I think that this kind of information that we're sharing is going to spark those kind of ideas, and I love it, and I hate to cut it short, but we do have more stuff on the agenda. So if you've thought of anything else that you're like, oh, can we see this, or how can we record that, please just shoot us an email. Let Madeline or I know, and we can always talk about ways to either add a question or change a tracking, or we can think about it most definitely. So thank you all very much. I am going to move us along because Michelle has a quick thing that she wants to share. Christine has a question, and Molly has an update. So go ahead, Michelle.
Hi, guys. I will make this quick. So I just wanted to touch base with you all because there's been a pretty significant update to the assessment. So you can find the most current version of the assessment in STAR. So there's three versions. There's the full assessment with the SASH coordinator and wellness nurse combined, and then there's just the SASH coordinator assessment, and there's just the wellness nurse assessment. And so depending on how your teams like to work, they can choose what's best for them. Please know that there were some really important updates to this assessment, including questions and new questions and new screens. So we really need, what's their question?
Yeah, and you can fill a chat thing. I'm sorry.
Hold on, guys.
I just have it right here. Yeah.
Scroll it down.
Keep going. Yeah.
What's the yellow coloring on the tabs mean? Sorry, Kenneth, what tab do you refer to?
That's in PHL. That's in PHL, and it's actually an issue that we're trying to get PHL to take away. It doesn't mean anything to us, but there's some other customer of PHL that utilizes it in a way that it's sort of like a check mark. So like if you went in and completed this tab, it highlights it, so then you know, quick view, that you've done them all when they're all highlighted. We don't really use that, and it's more just confusing than anything. So we have asked them to disable that feature in our instance, and they're working on it.
Thanks, Melissa. So I just want to ask you to encourage your staff to make sure that they start using these new versions of the assessment as soon as possible, because we do want to capture that important data. And if you know you have staff who kind of have their own little version of the assessment, we need to make sure those get updated too, because it is really important information, such as med adherence. I think there's a cholesterol question. So yeah, we just want to make sure that we're getting the data that we need as soon as possible.
And the assessment is no longer in the order of the tab.
Yes, and yes. So another thing about the new assessment is not just content, it's the way that it's actually laid out. Previously, we designed the assessment to follow the order of the tabs in PHL just to make data entry a little bit more easy. And now that PHL is not this big, scary new system for most of us, we revisited the assessment to hopefully make it a more kind of participant-friendly flow to it, so that the order of the screens has changed in hopes that the actual experience of sitting down with a participant face-to-face and doing an assessment with them just makes a little bit more sense. It's a little less clunky, like, how did you get from this question and now we're jumping all the way over to this question? So we put a little bit more thought into the order of the questions. Yeah. So any questions about the assessment update? I just encourage you guys to go check it out. It looks different too. And I'm totally open to feedback. If you have ideas about how it could be improved further, I do plan on quarterly updating the assessment. So
that's right. So I would just say maybe tell staff not to print off like a whole year's worth, but to just print off enough to get them through a quarter, because we're going to try to do updates to the assessment once a quarter, and that way they won't end up with a bunch of printed assessments that are out of date.
Yes, thank you, Melissa.
Sorry, go ahead, Michelle.
Yeah, no, that's good, thank you. And then the other thing I just really wanted to quickly pass along was the assessment declined visit reason. The staff are definitely using it, which is great. I am seeing the most use with the wellness nurse assessment as opposed to the SASH coordinator assessment, which kind of makes sense. The wellness nurse assessment is considerably more time-consuming for a participant. That being said, some of the rates at which the wellness nurse assessment being declined at some panels are higher than I would have expected. And so I just want to let you know that if I see that a panel has more than 10% of their wellness nurse assessment declined, I'll probably just give a call and just be like, hey, what's going on? Just because we really want our participants to have these assessments, and you know, there's so much valuable data, and I understand that it is person-centered and people can opt out. But I feel like over 10% is just worthy of a conversation, and make sure that our staff is offering it in kind of using good language and you know, kind of almost selling the product, because it is really valuable for the participant too to get this information about themselves. So anyway, I want to let you know that I will be kind of looking at that declined assessment rate in the panel. And
Thanks, Michelle.
Yeah, sure.
I was just going to say that we did actually, through this conversation with a panel, uncover that there was a panel out there that said they were just offering it. And so it's like, oh, do you want a wellness nurse assessment? And people be like, no, I'm all set. That's maybe not the way we want to be talking about it, because it is more valuable than that. So we had a really great conversation with that panel, and they kind of understood. So this is the kind of conversation that we're just going to be reaching out to have with people to kind of understand why the numbers went up, because I think on average there were always a few people in a panel that didn't want to do it, and that makes total sense. But when it starts becoming like more people in a panel that don't want to do it, then maybe it's something about the way it's being explained. So I'm going to move us on because I want to make sure we get to Christine's question. So Christine had a question, and I can let you just go ahead and ask your question if you want. Christine, are you able to unmute?
Hi, yeah. It was just really, I was just wondering what other people did around any documentation at home. A lot of coordinators and nurses are asking, you know, due to bad weather, are they allowed to bring any material home or do any documentation from home? And then the last part was really around, I have a nurse who is really a community nurse, and she travels a lot. And so is it expected that she would bring her materials back to the main office, or can she go home with those materials and then bring them back the next time? I just didn't know what other people were doing or what was appropriate.
Christine, this is Becky, and because we're mostly community, we definitely do work from home some days, and our wellness nurses also take things home. It's just they have to have a locked box or a locked place to keep them.
Okay.
They have those audit boxes that I used to use as a therapist that you could lock a couple lock on the top, so it's like a bigger box briefcase you could put files in.
So our executive director. Okay.
Mm-hmm. No, go ahead.
Oh, so our executive director is the compliance officer. So she felt like, through HIPAA, that it was a HIPAA violation to bring materials home. Is there any feedback on the HIPAA rule?
As long as it's locked, you're fine.
Yeah, there's no HIPAA. HIPAA does not get into that kind of granularity. I'll tell you that. I mean, sometimes I wish it did. But it's basically like you have to follow privacy, confidentiality, and if you don't, then you're going to be audited and this, that, and the other thing. So your staff know, because of the training, that they have to make sure they're protecting this information. And so our kind of practical on-the-ground advice has been, have a locked, like we said, suitcase, storage bin, file cabinet at home, whatever it is. And we have had situations where stuff has been left in a car in someone's house, and then that car got broken into. So even though it was locked in the car, that's not going to work. So staff have to think that stuff through. So leaving their box of assessments in the car overnight, even though the car is locked, that doesn't cut it.
Okay. And what about like space in a house? Does it need to be a HIPAA protected area?
If it's in a locked box, then you're okay in a house.
I'm talking about if you were entering data in your home.
Well, I mean, you would want to make sure, just like you would at an office, that you don't have people looking over your shoulder, kind of thing. So it's the same, I think, as if you're in your office space.
Okay. And one last question. And then in any computer, you can just log into PHL and it's secure.
Yep. Absolutely. Yeah, that's one of the very obvious positives of PHL is that it is actually a compliant web-based system. We're just laughing because it's nice to actually.
Those are medical pros and cons.
Yeah, that's an obvious pro. We don't always have those. Those are really good questions, Christine, and I appreciate Chris's concern about that, because we have to take this so seriously, especially since as housing organizations, we're still, as I've said before, the new kid on the block with, really confidential health information. So our staff need to be, trained yearly like they are, and, the impetus is on all of us when we're talking to them to underscore the importance of how they handle that information, and for them to be thinking about it of, what if this was my information? What if this was my mom's information? That kind of thing. So really good conversation.
The organization I used to work with in California, we had actual guidelines for people, because all of our therapists were community-based, and so they would travel all over Oakland and, various parts. And so we had a guideline of what you would do and how you would transport data and information, and you were expected to follow those. So your organization may want to come up with some sort of guidelines for staff around, if you're working from home or in the community, this is what we expect.
Okay, thank you.
Those were great questions. So Molly, you've got like 2 minutes left. I don't know if we want to ask everyone to stick around for a few minutes, or
it's up to you. I can do a quick update. So the main thing I wanted to let you guys know, and I feel like I'm a broken record, because this time of year this will be the third year, I've had to raise the issue of our budget at the state level. Our funds that we get from DAIL, the Department of Disabilities, Aging, and Independent Living, is under scrutiny. And this year it's a little different in that the proposed budget by the governor's office included a cut to the SASH administrative funding for 2020. And for the past couple of years, it's been level funded by the governor, but then we've had legislators that have gone after it to try to fund other important programs. So we've had this happen before. It's just a little different wrinkle. So we will be getting information out to all of your organizations today, just giving kind of the facts as we know it now. We're actually getting some conflicting accounts of what the actual cut is. The commissioner of DAIL said one thing, the secretary of the agency said something else. So that's all. So we're trying to get to the bottom of that. But But the bottom line is there is a cut proposed to our administrative funding that we get through Dale. And just as a reminder, that funding includes not only kind of the statewide infrastructure, all the, training we do, the kind of data analysis stuff that Madeline just shared, all of this work, to support all the panels across the state is funded through these state dollars. But additionally, the HOS grants are funded through these dollars, and those of you that have HOS grants, you know what I'm talking about. Those were in place well before SASH, but that's included here. And then funding for our partner staff at team meetings is covered with this funding, the $50 per hour. So it's a number of things, and again, we've dealt with this the last couple of years, so we'll deal with it again, but we will need to reach out to legislators, and we'll need you all and your executive directors, especially, to be reaching out to new legislators, because a lot of you realize there's a whole new crop of, especially representatives this year. I think like 30 or 40% turnover. So there's certainly the chance that there's some representatives at the State House that do not know about SASH. So now will be the time to just kind of reach out and start doing that. We're really early in the budget season, so we have to be strategic about the timing. Right now, to be honest with you, what they're doing at the State House is doing what's called budget adjustment to the 2019 budget, because they always have to look at that and make adjustments. So they're not, for the most part, even dealing with the 2020 budget. So we don't want to flame out too early with attention on this. So there's some strategy that we're working on we have a couple lobbyists that all the housing organizations pay for. They're down at the State House. So trust me, in really good communication with them. In communication with leadership already in the State House. So we're on it. We're going to fight it off, but we do need to enlist your help as much as possible. And again, I'll be getting information out to all of you in the housing host organizations today with basic talking points and kind of the facts as we know it right now. And, as we need specific help with a specific legislator, I'll be reaching out individually because depending on where you are in the state, we may need, you might have a representative who is chair of the Appropriations Committee. Well, guess what? I'm going to tap you if that's the case because I need those personal relationships that make the difference, and it's the stories that get told that make the difference. So anyway, we're at it again, and so I just wanted to give you that heads up before the email goes out later today. Any questions on that? I know how to silence a room. I will keep you updated.
Okay. Thanks so much, Molly, and thanks everyone for the good call. Sorry we went a little over. Have a great day.
Thanks.
Bye.
Bye.